Thank you, Dr. Bender, for joining us. We have started these coffee and conversations for our Hirschsprung's community about a year ago. And as I was just saying offline, before I introduce you, we're so thrilled to have you and have your perspective as somebody that comes from your background. Dr. Bender and I read your bio, so you might have to jump in and help me, because there was a lot of words I was like, I've never heard of a psychopharmacologist, psychotherapist. There was a lot of things, but you have, we were just chatting, said that you have been specializing with children with GI issues for the last 25 years. So if you could tell us a little bit about you, that would be great.
Yeah, no, I'm really delighted to be here, and that hope I can be helpful in answering questions, and that this is my sort of bread and butter on Thursdays. So that on Thursdays, I spend 10 hours at Mass General last 25 years and only see kids referred directly from the Pediatric GI group. And so that includes kids with all sorts of chronic illnesses, including Hirschsprung's, also encopresis, also functional abdominal pain, also functional disorders where we sort of know that there's a special neurologic link between the brain and the gut, and that stress can be really expressed in the gut. And so that can be on top of any anatomical or systemic illness on top. And so we unravel it. And so I think in terms of how do I approach it, I have always said, I approach it in the way that works. And so in some kids, that's going to be psychopharmacology, which makes a huge difference. In other kids, it's going to be psychotherapy. In other kids, I'm on the Zoom meeting for the special education meetings for the school, and I'm advocating. In other situations, we think about changing the school. I'm working with the family. I'm seeing if there's bullying. We try to do neuropsych testing if we think there's a diagnosis not there. And so I feel like I'm captain of the ship in a way. I often make a team. I bring a therapist in. I do psychotherapy in other settings. I'm very familiar with it. And so with that, we've had great success. So I'm hoping to be able to tell some of my pearls today and be helpful.
Oh, well, thank you so much. Again, as I said, we feel like this has been a bit of a missing link for us. We have such an amazing group of physicians and specialists in Hirschsprung's, but this has always been an area where I know, as a mother who has a child who has Hirschsprung's disease, as well as working with this organization for so many years and being on that front line of communication, we know as parents that there's definitely so many different factors beyond just the physical. So thrilled to have you. And so with that, we'll let you sort of get started with your presentation. Then we've left some time. As I said, some people have emailed in, they have questions, and we'll address those. And then of course, we'll open up chat.
So it's interesting. Sarah had emailed me and we checked repeatedly, and I asked if I needed to have a presentation, and she said, no, I would be only answering questions.
Okay. So, well, I didn't know if there was anything you want. Okay. So yeah, let's go right to that.
I can always talk top of mind and just sort of do it. And then maybe that can lead to some questions. And I guess sort of the thinking is, in looking at the research of Hirschsprung's, it seems that even with people, kids or adults who are struggling medically, there are some who really report a good quality of life. And so then you also think that there's so many who are struggling less physically, and then it's easier, right? But that even with holding on to and dealing with complicated medical issues, there are people who are thriving. And so we try to think, okay, what makes a person resilient? Mm-hmm. What makes it easier to do well? And the way I think about it in a way is we think about a seesaw, right? In terms of like positive and negative things in life. And so if you've got Hirschsprung's, it's a big boulder heading you towards negative. It's a harder thing to have. And I'll talk to my patients with other GI diseases about like, you've got like a boulder in your backpack, like it's heavier. Mm-hmm. And so then what you want to do is really think about what are the ways that you can balance it, and that you're actively thinking about how to move it this way. And so I think that thinking, well, what allows a person to manage? And I think, the clear things, advocacy with medical care, getting your worries addressed, something can be done about something. Moving into the school, how can the school be supportive? Full bathroom access, nurses' bathroom, all these different things. But then thinking about psychological health, right? And so thinking, what makes a person feel good about themselves. And so I think that when you have a chronic illness, it makes sense that mental health is protected and addressed in an ongoing way earlier, because you've got this boulder sort of pushing you down a little bit.
Right.
And so that means thinking about emotional intelligence, investing in that. And I can talk about some books that I think are really great parenting books that help build self-esteem.
Okay.
Some parenting plans for adolescents and how to help the teenager have a sense of agency.
Right.
And then also thinking of, in latency, you are what you do. That kids, this is where, they'll have the paper bag and they'll say, bring 3 things in that sort of identify yourself.
Yeah.
Like that's such an important thing. And to have ones that aren't related to physical health. So those are things that you can do whether or not you're feeling, just exactly yourself at that point. And then, having a lower threshold for psychotherapy and for psychopharmacology, which is meds, which can be transformational, right? And so that people often think about medications for kids and worry. Mm-hmm. But I think if you see a kid who is meeting an anxiety disorder and you've given therapy a try, this can change their entire outlook. This can make their life so much better. Depression can happen in children. Right. Medical illness is a risk factor for depression. We have tried and true approaches. A wonderful book for parents worried about psychopharmacology for kids is Straight Talk About Psychiatric Meds for Kids by Timothy Willens, who happens to be my boss, but that's not the reason. I like him, but he's a great doctor, and it goes through psychopharmacology for kids. It helps people not feel scared of it, and it can make a massive difference. So I think that my overview would be thinking about how to increase resilience, and that makes to move your child or your adult over to the side where their quality of life is very good, which is so possible despite what you're dealing with.
Right. And I think, because again, we hear so much from parents with kids of different age groups, right? And so one of the big obstacles I know from families, and again, we run the parent group, so we hear it and I see it, is potty training. That is really where families go, okay, this is where we run into our first stumbling block, because we have a child who has Hirschsprung's disease. This child may be doing really well. This child may not be doing well. I mean, our families and our patients, it's a whole spectrum of possibilities post-surgery. But one thing we hear over and over again is that potty training is something that is so frustrating because nobody is addressing expectations. And so families will often say, what should my child be doing? What should my child be doing by which year? What is the mark? And as a mother is having a child who's now almost 14, I'm like, shed the shoulds, because there is no shoulds in this scenario. Every child's going to be different, but it does become a real sort of emotional place for families, for caregivers, because they desperately want their child to be fully functioning. Potty training also determines usually whether you can attend school, whether you can attend preschool. Do you have to send your child to school with, I've heard families say, we keep them in good night. So we've put full-size maxi pads in their underwear. So now they're that child that has that makes them different. So that seems to be where we really notice the starting point of a lot of the emotional stuff. And if you could address maybe your thoughts on, that sort of situation. I find it's often starts with the families and the caregivers that go through this emotional roller coaster because they want their child to be achieving normalcy and being like all the other kids, but it is definitely a struggle. And then I find that afterwards, of course, the kids are struggling with that. So that age group of age 3 to 5.
I think the first piece would be to see the difficulty as sort of a medical issue with psychological ramifications. Mm-hmm. And that I would assume that families after sort of surgery or, that they're sort of ready to potty train, they would say, oh, this is like a psychological thing now, that they might sort of blame. There might be like blame that takes over. You have to let me know if that fits with, and so then that doesn't help anybody. And I think that there can be, I mean, I remember just when my kids were really little, now they're, both adults, but like who got potty trained first, who were not my children, but like watching the 2-year-old parading in her underwear and the mom being like, no, it took us 3 days, and sort of feeling like, oh my gosh, am I behind? And then if you've got a kid who's got a medical disorder that is going to make it slower, that it can be very easy to move into what am I doing wrong?
Yes.
And I think that maybe the first piece to put it is that anybody who is listening to this is a winner parent because you're showing up, because you're concerned, because you're trying. And no parent is perfect, and no parent has an easy time with each moment. And that you're having, by having a child with a medically complicated disorder, you have what I call fast pitch parenting, which is there are parents where it's like a very slow pitch, and then they swing the bat and they get a home run because they have a compliant child whose body is working, who goes to bed when they're supposed to and eats everything. And, and that parent then feels like really, really great about their parenting, but that's not because of the parenting. That's a slow pitch situation. That's easy. And that when you have a medically difficult child, it is harder. And so then to sort of first note that, and to try to be compassionate about that, the way you might be compassionate if this was your friend's child, that you would not be blaming them if there was a setback. You would not be blaming them if it took some creativity. Right. So I think then the next step would you want to talk to the surgeon or the GI doctor and ask about what sensation can you expect at this point? What do you expect the child to be able to do? Because what if it's a point where the child isn't able to really feel, or what if you've got a child who also happens to have ADD, so they're inattentive, and it's just going to take a little more maturity before they're ready because they've also got this medical issue. So you want to sort of know where you are before you set up your plan. And I think a lot of times parents will plan first because they have a goal versus looking at what the situation is and planning for that. So then you'd look and say, okay, so they're telling us that sensation is enough, that we should be able to start toilet training now. And then you would sort of think about, okay, let's approach this in a way that also supports the family, right? So you want to think about, let's do this in the summer. Let's not do this before the start of preschool fall, like a week before. And you sort of say, well, is this going to be a problem being in diapers? Well, it seems that any good school should be absolutely able to manage this in a way that is shame preventing and that is protective of the kid. And an interesting, I think, thing to know, because I've seen a lot of kids with encopresis, is that it isn't encopresis that ends up being a social difficulty. I've had patients who are like presidents of their middle school class who have active encopresis, who are having accidents that are like significant twice a week. And that that alone doesn't do it. There's often something else. There's a way that the kid needs a retort, like they smell something in the class and they say, everybody look at your shoe, did anyone step on any dog stuff? Like that's what this kid would do, and everyone just sort of went with it. So it's unexpected, but alone encopresis is not enough to cause social difficulty in my experience, which is just me, but it's a lot of seen encopretic kids. And so to think like, oh my gosh, there is this worry and hurry to get this taken care of, and then that adds anxiety, and then everybody feels so tightly wound, and then you're sort of setting yourself in any parenting situation when that's the case. So then you think there's two ways to sort of, I guess, three approaches. One is that making sure, in treating constipation, and this would be where working very closely with your PDGI doc. And I wrote a clinical perspectives in the American Academy of Child and Adolescent Psychiatry on this, on the child psychiatrist's approach to encopresis with Evelyn Barode, which maybe there'd be a way to find and share. But we talk about the optimal mix of mush and push, right? So you need soft serve ice cream so it's not going to hurt, and you need push so that the kid says that they can get it all out. and that those two have to be optimized before you start toilet training, right? So if you start toilet training and the kid is having little stools, which in Boston we call munchkins because they look like the little donuts, right? You know, or bunny poops, like you're not going to be successful. That child needs to be having either a very smooth log that can be expelled quickly and not painfully, or even better, like a soft serve ice cream where it comes out in 5 minutes and there's not really that much straining and it's done. And then when you ask the kid, do you feel you can get it all out? That hopefully, if you know we have enough anatomy corrected, that they can say yes or no, and that there may be a way that these kids say maybe, and then you still just work with it. And that ends up being a mix, usually, I think, of a softener, which would be like Miralax or apricots, or but just Miralax probably the easiest. Making sure you drink it all in one sitting. You can't nurse it; it doesn't work that way. 8 ounces, and then push. You would work with your GI doc or pediatrician of what's the push. Because a lot of times the push seems like it's going to be it's going to need some assistance having had Hirschsprungs, right? And so your options are like a magnesium product, some sort of magnesium supplement. My trick of the trade is Duplex compounded, which is vesicodyl, and we do 1 milligram per milliliter. We choose a flavor. They do it in compounded pharmacies. You give it at you give it at dinner. And like it kicks in like 2 to 3 hours later, you have a sitting time. You realize the kid is not going to feel it. So you just have to have a sitting time where they sit for just 5 minutes. And the vesicodyl kicks in and they evacuate completely. And so that's a really good one, because if you give a 5 milligram vesicodyl over the counter, that's crampy. It feels like a bomb. It really, really hurts. This, you start at 1 milliliter and you edge up each day. So you're finding the optimum dose for results. And then you need to, like with any kid, it takes only 48 hours of not pooping to cause an impaction. And so there needs to be like a rescue therapy in place, so that if you're pooping in the night, right? So if you don't poop Monday and you don't poop Tuesday, by Tuesday night, there is a plan with your GI doctor of what little extra something you're going to get. And it might be an extra cap of Miralax plus an extra vesicodyl the next day or the next morning. But you'll have something, because the longer you wait, the harder it gets. All the water gets reabsorbed. And so that kind of approach, I think, can be really, really effective. And then you want to watch, you want to have a behavioral program. What I always say is that kids should get credit for trying, not for success. You can't, and I think that's actually a really good approach to parenting in general, so that your kid studies and they do their best. They don't get an A, but they did the best, and they get a C, but they really tried. They get credit for trying, right? That's really important. If a kid who's having trouble learning how to stool sits for their 5 minutes, you can do a couple things. They can have a little candy after, some Sour Patch Kids, a Tootsie Roll, something, which Tootsie Roll would be kind of funny. Anyway, but just a lot of poop jokes are involved. But then they would also think about it a little like Chuck E. Cheese. Like, so you would say, oh, you get 2 points. I don't know if there must be Chuck E. Cheese in Canada, or,
There is, but a lot of our people watching will be in America, so they'll get the reference.
So you would get, let's say you get like 5 points. You get 5 tickets, 5 points for doing a sit. When you get 20 points, you'd sort of say, then you can cash that in for, do you want a little bit of extra screen time? Do you want to go to the ice cream place? Do you want to have ice cream before dinner? You could have a whole list of things that they could cash in for, so that they would get a little something each day, but they would be working towards bigger prizes. The prizes need to be affordable for the family and not too huge that the kid says, I never need to poop again, because I now have, one family did, like a Lego Star Wars, $100 set, like I'm set for life. Thank you very much. No potty for me. Right. And so that you don't do, because there's no reason to stay engaged. It has to be things they really like, that are smaller, and that you then are really talking about your pride, that they are trying, that they are sitting, this is a harder thing for them. Other kids have not had to manage this. They've had surgeries, and so you are giving them prizes for their effort. And kids really, really like this. They feel heard. If you have other kids who do not have a medical condition, they need to work on something else and have a similar thing, so that you don't end up having jealousy between them. And I'm sure there's something the sibling needs to work on too.
Right.
Yeah,
Right.
everybody
That-
needs to work.
That's excellent. Thank you. And so you keep saying 5 minutes because that's another thing that comes up a lot because parents will say, I feel like a horrible parent because I have my kids sitting there for 30 minutes or we sit until we get it. And so if you could sort of give us some parameters about that because parent, a lot often we don't know, and with Hirschsprung's kids, it's like we don't know, is it going to take more than 5 minutes? Like how long was reasonable between at that age?
So I would specifically check with your pediatric GI doctor and surgeon who will know the anatomy of your child,
Right.
right? Because I don't know exactly how each kid is going to be
Right.
wired. And I think that it could be, dangerous for me to say this is going to apply to everyone.
Right.
What I would say is that there's likely a medication dose that it's going to make it go much faster.
Okay.
And so that's why if it's taking that long, my guess is you need more push.
Right.
Right. And so that if you just give Marilax to kids who have a contractility issue, their stool softens and it just sits there.
Right.
And it doesn't go anywhere and they never go. Right. And then at a certain point, they may have an accident. And so what you need is it's soft and then that there's something that helps push it out.
Right.
And so you really have to have that contractility agent. When they're older, I'll use coffee. For high school kids, they'll go and get a iced coffee and feel very big, and that will be what works. But when they're this young, I would go with, talking again with your pediatric GI doctor, sometimes senna, sometimes magnesium. They'll have a whole bunch of possibilities, but my favorite's the duplex compounded.
Okay, excellent. And so now we're in September, kids have gone back to school and we're in this, and there's a lot of families that have been, emailing us and saying, okay, my kid's in school, and we're getting all kinds of questions. And actually when somebody just emailed me now, I noted it came in, their child is particularly gassy. And they can't control this and they're struggling. They're in grade 1 and they're struggling with this and how to handle it. And the parents asking like, do you have any tips on sort of how to address that? Like, because their child isn't that extroverted kid. She says that he's not the kid that's going to make light of it. So, but I also, he's feeling shame, right? So how do you normalize things in a setting like that for your children when it doesn't feel normal, if that makes sense?
And how old is he?
Grade 1, she said.
Grade 1. So I think first I would talk with the teacher and say, so that he can feel hopefully very cared for within the classroom.
Right.
Second, I would see if there's any way to find rhyme or reason or pattern to it. Is he really gassy because he's constipated? That would be a classic reason a kid would be gassy, in which case then we run to part 1 of this, right? And so, actively making sure your child is pooping, every day or every other day is going to really, really decrease the gas, and sort of thinking about that. Because gas in a way is like your body is actively trying to expel something and having trouble.
Right.
Right. And then you could sort of take a look and say, is this something that is worse if your child has more lactose products, more milk products, right? So if this is a kid who has a big glass of milk every morning and then goes to school and is really gassy, could you substitute it for an oat milk or for some other thing, or a smoothie or, with soy milk or, something different, or give lactate. But I think so. I would think creatively with the GI doctor and seeing if there's any pattern and take sort of a deep dive in.
Right.
So then he's in his class and he has gas. So one question would be to help him potentially lean in, which is going to take some role playing at home. Right. So let's say it becomes very clear that it's him that's having gas.
Yeah.
And he is a shy kid.
Right.
So this is hard, but you would lean in potentially and say, I like to let it rip. Little boys love to talk about poop, right? And there is a way that if you try to hide it, the more you try to hide it, kind of the worse you feel so ashamed.
Right.
Right. Yeah. And so what if it was something like, or it could be like, I have a really sensitive nose, and he goes to school with some sort of spray that you work out with the teacher. And he's like, I think we need a freshening up right now. And he takes his cinnamon spray and right, so that he feels he can do something.
Right.
You know, and so I guess those would be my first thoughts about it. That kind of, there's a way that if he feels it's shaming, and then we add in like, oh yeah, no, this is awful. Like, I'm so sorry you have, like, that it amplifies it.
Okay.
Where at the end of the day, right, here is this sweet little first grade boy who's probably got all sorts of interests and all sorts of things to share. And every now and then he has gas, right? Yeah. And if we can say like, I tend to be gassy. You know, I tend to, you know, so then in a way you are empowering him.
Right.
And if the kids are like, yeah, that smells gross. And you could say, well, I have rose, cinnamon, or blah, blah, you know, he could come out with like an assortment. What do you think we should do? You know, this is, you know, so that it, in a way, just owning, if there's a way that I think that it may take some time for the parents to do that as well, but little boys love to talk about poop and pot. Like they're potty mouth by definition.
Okay, so then I guess to address the population of kids that we have who have colostomy bags and buttons and things like that, because they too, like you know, a lot of them are starting to go back to school, starting new schools, they're in that phase. And so I guess a lot of the same rules would apply in terms of sort of taking ownership of it. So there's no room for shame. That would be your suggestion? Because a lot of our families too, they say, oh, my kid's got a bag, and again, he's got to go to gym class and this kind of thing. And so, you know, they'll say like, we feel terrible because they always have to explain. And a parent's always going to feel protective of that, right? Like you hate that your child has to go and explain. But what would be your advice to parents in that situation? I find often that we struggle more sometimes than our kids. Our kids act like this, and we'll be at work, you know, texting the group or texting our doctors and be like, okay, like they're in there, you know. So what could you possibly, you know, share with us in your pearls of wisdom, because I know you deal with this for a long time, that might help us feel better about that?
I think I would try to follow the kid's lead versus leading the kid, right? Yeah. And so that when you have a child who's got a bag, and I've worked with kids with ostomies, and I've had kids go to college and become sexually active with ostomies, right? Like, so, you know, that there's a way that their body is different. It is harder. And that they're going to have to learn how to communicate better, more quickly than most kids their age. Yeah. I think that, I guess the first thing is I would ask to see if it's even top of mind for them, right? Because the parent might be like, oh my gosh, what's going to happen in gym class with your bag? Do you have a plan with gym class for your bag? And I think I would ask the kids, so tell me about this upcoming year. What's your schedule? What are you looking forward to? I would ask a lot of questions. What are, you know, what's going on with this teacher? The question about the bag should be embedded with like 2 questions on each side about other things. Right? Because you don't want the kid to feel like they are defined by this very minimal part of themselves. So then you ask sort of, okay, how was your English teacher? Who'd you eat lunch with? How are things? Any concerns about the bag? Now, what are we doing after school? And you need to eat your snack, you know? And so then they let the kid lead. And so then the kid says, yeah, I feel worried about my bag. Then again, you don't want to project your worries. You could say, tell me what your worries are, right? Because they could be really, really different than what your worries are about the bag. And that also their body is the bag. They are living with that. So there's a way that they're going to, you know, they often feel, it feels really foreign and strange and icky at first, but that there's a way that it becomes part of them. And, you know, it is part of them. And so that they will be watching your reaction of distress about this part of them. And so I think sort of saying like, this is not unlike having a major peanut allergy and having to navigate. This is not unlike having a boot at the beginning of high school. And this is not unlike having to go to the nurses for your ADD medicine for many years. Like, it's harder, 100%. But let's work with it. Let's hear what's happening. What do you think about Jim? What do you feel like it would be helpful? Follow their lead.
That's excellent advice, because I do know, even for me personally, I've found over and over again that 99% of the time I was far more worked up about something than my son Malachi ever was. And so I thought, well, that was a lot of energy I put into something that materialized into nothing, you know? But I know these are things that we get reoccurring. I also want to let anybody know, I know that Nicole jumped in here and said that she brings body spray to school for Benjamin, and it's awesome. And so true, boys love poop and farts. So, so if anybody else has comments or questions, feel free to join in and jump into the chat. I know that with Nicole's son Benjamin, he's he's adorable, and I love how he tells the stories. He starts school and he says, "Oh, I have this and I did this, and sometimes I have to do that," and it's become really comfortable for him, and so that's been kind of fun to watch. Oh, another one. Poop is always a hot topic at our house.
Kids love to, I think, just like kids talk about poop, whether they have Hirschsprungs or not. I mean, every kid is talking about poop. It's like a very hot topic. And so I think kind of normalizing it, and sort of, I love that someone's done the body spray and it worked. And I'm so glad that, you know, that was a helpful idea.
Yes. And so another question for you that I had in my notes here that was coming up is, as we get into the teenage years. So, and you know, we refer to boys a lot because obviously this disease primarily is a bit of a slant towards it affects boys, but of course boys and girls. But as I have a parent who's got a daughter actually, who's closer to my son's age, and she says it's getting different now because they are becoming more independent. So this child's 14. She doesn't want to share with me. She doesn't want to let me in the washroom. She doesn't want, so now there's this real sort of two things I'm noting going on. And like, there's this, it feels like from a parental perspective, and I can relate just a little bit now, it's like, oh, you have all this independence. That's amazing. At the same time, I feel like I have no control over what's happening. And on the other hand, it's like you kind of, you know, what can we encourage? Because we understand it's important for that independence. So this mom is saying, I have no idea like how it's going in there anymore. And, you know, that can be a difficult thing for both. So what advice might you have to encourage that sort of, you know, teenage, they want to be independent type of thing?
It's a great question. I'm prepared for this one. So
good.
So, you know, I think that development has changed having a kid with a chronic illness from the jump, right? And so that parents, to protect your child, you are more involved in their business all through growing up. And it is hard enough when your child becomes an adolescent, but it is a more complicated extraction or change, right? When you've been so tight and working together, and you worry at a different level, and that you come by honestly.
Right.
And yet the developmental requirements of this age are the same. And it actually is really healthy to see the kid take control. Mm-hmm. And so I have a 3-word question that can be your best friend, which is, what's your plan? So if you ask a kid, what's your plan? That is respecting their independence, but it is also allowing you to see their thinking. Okay. And then based on their answer, you may have like part 2 or 3, right? So what's your plan in terms of the Hirschsprungs for fill in the blank? Mm-hmm. And then your daughter says, oh, well, I'm doing this and da. And you say, well, remember, I have a question. What happens if what happens last year happens again? What is your plan for that? How have you thought about it? And she says, oh, well, I don't know. Okay, would it be helpful to talk it over with me, or would you want an appointment with Dr. Blank, and so that you could have some ideas of how to think about it? Or she says something that's good enough. And I think a really important part of adolescence and growth is if your child says something that's good enough, even if it's not quite as good as your idea, and we know it won't be as good as the parent's idea because you have a lot of experience and you're a parent, you've thought about this way more. but if it is good enough, support it,
Okay.
you know, and then actively point out in detail what you like. I really like how you thought about this. I'm impressed how you know, considered this aspect. I really appreciate that you thought about this. I wonder what your thoughts are about that. Right. And so then what you're doing is you are scaffolding their adolescent development and doing what is really appropriate for this age, is that it's increasing their self-esteem. It's increasing their sense of agency. But by using that question, you also now know what's happening.
Right. Okay, great. And would you say two things? At what age do you start to encourage them to take that ownership, or you wait on it, or that independence? Like who leads that? Because on the flip side of it too, you have parents, and again, I've been at this for 10 years, so sort of being the parental liaison, so I've heard it all. And I'll often hear too, you know, that there's, you know, women who have said to me, mothers or fathers or caregivers, that said, you know, my child feels so dependent on me. And they're getting to an age like, do I start to encourage them to take independence or ownership of their own stuff? Do I hold on to that because then at least I know I'm in control? Like, at what point do we start that transition? Because it is unlike your friends, you know, my neighbors, they have a child the same age. They're not having these conversations of, they don't have that, like you said, that real connection of dependence because they have a child who's got a chronic illness. So.
Right. No, I think that the goals of parenting change when your kid hits adolescent, and specifically by high school more.
Okay.
Definitely by the end of high school, you know, 11th, 12th, you are preparing them to leave.
Right.
9th, 10th, you are preparing them for 11th, 12th. Middle school, it's the beginning of wanting them to have much more agency. Right. And so if a kid is really dependent, right, then likely they're anxious and they're not trusting themselves. And so while it is easier as a parent to stay directive, it's ultimately not in their best interest to just do that. And you want to start building in early around 12, 13, but increasingly as, you know, sort of this approach that you want to follow them. You want to move from being the engine to being the caboose.
Right.
And so thinking about how to do that, the best parenting book that I can recommend, which is actually mostly cartoons, but I think the best investment for parenting, or actually in any relationship in general, is called How to Talk to Kids So They'll Listen and Listen to Kids So They'll Talk. And it's by Faber, Faber, and Maslish. And it's on Amazon. It's like $15.
Yeah.
And it talks about how do you help a kid know their emotions and trust their emotions. And that is a way that a child or any person grows self-esteem.
Right.
And so child comes home and says, it was a really, really hard day. And they made fun of me because I farted, right? And let's think the first thing you might want to say is, okay, let's fix it, body spray. And I think you want to table that. Like, it's really important you'll get there.
Yeah.
But there can be like 7 responses. This is like page 5 or 6 of the book, that are easy to do, but not helpful. And don't help the kid learn their emotions and learn how to tolerate their emotions and feel validated. And so it would be like, oh, that's not a big deal, like minimizing, or, you know, I went through something worse, or let's fix it really fast. You know, it would be like, oh gosh, I'm really sorry you had a hard day. Like, I can imagine that would be really tough.
Yeah.
And then you can go in and say, let's think about what we might be able to do. But that book goes through multiple ways of helping a kid learn what they're feeling, know that it's okay. And that is one of the best ways to grow self-esteem.
Right.
And then it also talks about, it's sort of this interesting things when your kid does something, that you reflect on the process versus the product. These would be other ways to help self-esteem, which then would move them more to independence versus dependence. And so as a little kid draws a picture, and the parent who says, oh, that's brilliant, that's a masterpiece, you're the best artist in the world, that the kid can get a little bit attached to the hyperbole and just think, oh, I wrote this picture, I did this picture, now is this one also masterpiece? And they'll feel good in like for about 2 seconds, but it won't hold. Versus the parent who looks at the picture and says, wow, you filled up the whole page. That sun is so shiny. I see you love green. You have so many different colors of green here. Tell me about this flower. I love this picture because it reminds me of summer. The kid then takes in and feels, oh, I'm a good artist. So now let's expand this everywhere, right? And so thinking about, you know, wanting to focus on trying in school, not grades, which you can't always control. Right. Focus on the ability to keep going with things, with character traits, which you can work on, versus product traits. Like, did I get this many? Did I get an award? Did I get an A+? Did I, you know, and so that helps a kid feel confident, right? Which then a kid who's confident is going to feel increasingly ready to be independent.
Right. And I guess too that, you know, for a lot of parents, and I know this is true of me, I didn't have Hirschsprung's, I didn't have a rare disease, I didn't have a chronic illness. So there's a tiny bit of a disconnect, and I can't actually think back and relate to some of the things that they go through. And so as a parent or a caregiver, it's a bit like, you know, shooting in the dark. You don't really know. So you can say that, you know, well, I empathize, but I don't really totally fully understand because I didn't have to go through those things. So in your experience, are there certain commonalities or things that kids who have these types of chronic, and I think GI is a little bit different. For somehow we socially accept, you know, oh, that child has got an EpiPen. Okay, well, lots of kids can carry an EpiPen, and we socially accept that. Well, is it a little bit different when it's GI issues? Because it's like, well, that kid's kind of the smelly kid, or that kid has to go to the bathroom all the time, or that kid wears, you know, depends, or that kid does this, or that kid has a bag, you know? And so I think that it would be interesting to know if you've noticed any commonalities, because what I've heard a lot of, and what we've talked about a lot, is I think sometimes the kids are actually far more resilient and empowered than we give them credit for. It's a lot of the caregivers that struggle. But are there something with the kids that if you could leave us with that we should know, or that you've noted, or, you know, that would be great that would be helpful.
I mean, I think it is harder. It is harder to have GI things. You just want the kid to lead and tell you their story, right? That they say that it's harder, or they say that it was a hard day, or that it's top of mind for them. But, you know, there was a story long ago of a little kid who had Crohn's, who was on a very, very restricted diet. And he was stopped eating because kids were making fun of his lunch. And so he felt really ashamed, right? And he was a one session therapy, because in the therapy, we role played him saying retorts to me. This is unusual. It's a one session therapy, right? But that we role played me being the mean kid. Oh, what's going on with your weird lunch? And him saying, what he did actually is he went pow, pow, pow. And then I pretend died like multiple times and went back up, and he was like, and then he started saying it in words like, leave me alone, or what's your lunch, or why do you care? Why do you care is a great thing, right? And so sort of empowering kids to have retorts, right? There are bully kids who are around who are looking to find the kids who have a target on their back. And those are the kids who are fun to tease because it really hits them hard. And so when, you know, your child comes home and they're really, really hurt, you want to say, I'm so sorry you're hurt. It makes, you know, that sounds like a really hard day. Sounds like that kid was really mean. I'm so sorry you had to go through that. You don't stop there. Then you say, now we're going to role play what you can say if some kid gives you crap next time. Okay. They say, why are you going to the bathroom all the time? You say, why do you care?
Right.
Why do you care? What is it to you?
Right.
You have such an interest in my bathroom habits.
Right.
What is up with you? Right? You work on that. You work on being able to clap back, push back. Because I do think one of the things that can be just really hard is feeling helpless and feeling sad, and being mad is activating. And there is a reason to be mad if someone's giving you trouble.
Yeah.
And so, it's very hard to think on your feet, but there are some retorts that work for almost anything, which is like, why do you care, or whatever.
Right.
And then you work on it a lot. And so then the kid says it. And what's really interesting, so the mean kid says their thing.
Yeah.
Your kid doesn't even need to say it back to feel better. That's what I've learned. They just need to think it.
Yeah.
They just need to have in their head. So the kid comes up and is like, oh, you're going to the bathroom again. And, they could roll their eyes and be thinking like, why do you care? Oops, I didn't say that fast enough. Oh, now they're across the room. Okay, I didn't say it this time. But they'll feel better.
Yes.
Because you're empowering them.
And you've given them this tool set, which is really interesting for parents, because they know, and again, I want to encourage anybody, if you have any questions or any comments, I know we've got another 10 minutes, but I know that it's interesting because my son, when he was in grade 6 or grade 5, I got a call from the school one day and they said, Malachi's left and he won't come back in the classroom. So I'm racing down there, and I guess a child had said something to him and he was hurt. And so he just got out of his desk, went to his locker, got his stuff, and left the school. And so I pull up and the teacher's outside looking completely panicked and said, like, he can't just leave. Like, you have to tell him he can't just leave, and et cetera, et cetera. And I said, Malachi, what happened? And he said, well, so-and-so said this to me, and you said I don't have to stay in this situation that's abusive or toxic. So I was like, okay, so I need to work on what tools I give, because he got me there. I looked at the teacher, I went, well, that's true. So I guess we'll be back tomorrow. Because I hadn't prepared Malachi or myself for the dynamics that could occur. And so I find that that just cracked me up. So now he has that trick in his box. Can't
wonderful story though. What a wonderful story about him being like, I'm not going to take this. Yeah. He didn't do something unsafe. You'll never forget it. He'll tell his kids about it. Right. And so, but I think sort of thinking, okay, this is one for, our family book, but you can't do this in a regular, this was not quite exactly what I meant. And you know that, likely. But let's think about what other things. And if that kid is at your table, can they make it so that kid's not at your table? Yes. If elementary school, like, kids' weeks rise and fall based on who's on their table. Sure. If you've got a kid who, you're feeling is a little more sensitive, you talk to the teacher and you sort of see if you can try to have a little bit more of a sensitive table for them. I think that's appropriate. Okay.
Great. So we have some questions here from Jordan. How would you address the claims of the group Parents Against Miralax? It has more than 25,000 members. These parents believe the drug's active ingredient, polyethylene glycol, or PEG 3350, is triggering the neuropsychiatric issues.
So I know that there was a study that was going to come out and really address this. I think they were doing something at a academic center to sort of put this to bed once and for all. And my sense is that they're finding no results, like there's no problem, and now they're having trouble publishing because there's no problem and it's hard to publish negative studies. It's like the anti-vaxxers is my take. It's like there is no scientific evidence. This stuff is not absorbed. Right. If your particular child, you notice something on repeated stuff, right, that they look different, it's possible we don't know something yet. There are many other ways to soften stools. You could do colace, you could do apricots, you could, you could do different things. But I just think it's hard. You want to tune out the voices that lack scientific basis, that have people revved up that are making your life harder. Mm-hmm. Sort of in 25 years, I have seen innumerable kids on Miralax. I have not seen one that has any of the OCD spike or something that I think they talk about. Okay. I worry, what do they say sometimes on Twitter? It was like, oh, the person that was the COVID expert today is now the government expert who is now, like that people all of a sudden have expertise so quickly and a way to talk about things, whereas like then there are people, following for, Bob Wachter on Twitter is this UCSF ID doc who is very thoughtful and presents things and has expertise, right? I just think find me a pediatric gastroenterologist who wants to talk about this. Find me someone who is a physician, who has worked with these kids, who understands the pharmacology, and then let them talk and I'll listen. Right. But I think having anyone who is not medical professional actively talk about something based on anecdotal evidence. I mean, that's what, there's no evidence that vaccines cause autism.
Right.
We now have polio in the wastewater in New York City because so many families have not gotten their kids vaccinated for polio because of this worry that it has no scientific evidence.
Okay, great. Says, thank you. It has created unnecessary panic for us parents trying to navigate this disease in our young kids, 17-month-old. Appreciate your input.
Yeah, no, I feel like a piece of parenting is learning how to block people in your head, right? That you are going to hear people giving all sorts of parenting advice, Hirschsprungs or not Hirschsprungs, that is painful and judgy and shameful, and in this case, not scientifically based.
Right.
And I'm so glad if my reassurance can help you do what's right for your child.
Excellent. Thank you. So our next question is, what about if they don't want to talk about their condition in poop? My son is 5, and if I try and ask him about it or his bum, he won't answer and really clams up about it all. I try to do it in a jokey, fun way, but it just doesn't work.
What would be the reasons you need to talk about it? I guess that would be the question, right? Is this something where the parent is feeling like they want to check in, but the child is actually doing what they need to do? Then I think that you can sort of let it be. A lot of times development catches up. The child learns how to talk about it more over time. Mm-hmm. If there's something that's really necessary to talk about, you could wonder about having, you could try having someone else in the family try talking. You could have the doctor talk. I think I would actually learn, like, what do you absolutely need to know? What's the need to know and what's the want to know? And then the need to know, you can figure out a way to address. The want to know, if everything's going okay, just let it be and watch, that it just might feel like too much and too intrusive. And then you can actually ask the kid, right? You want to put in words their actions. You could say, does it feel like I'm getting in your business by asking? Or they might not understand that, right? Does it feel too much for me to ask? If they know the word intrusive, does it feel intrusive? Does it feel like you don't want to talk about it? Mm-hmm. And then they say, yeah, mommy, I don't want to talk about it. And then you could say, you know what? Can you tell me when you don't want to talk about it? Is there any part you do want to talk, you'd be okay, or all parts? And so if your child says, like, I don't want to talk about it, that is a step up from just clamming up, right? So then they are identifying their experience and putting it into words, and that's a parenting win.
Okay. That's excellent advice. I know it's very difficult from a parent perspective. Sometimes you worry, of course. Are they holding on to something that they're not telling us, and we need to dig in there? So I really understand that from a parental perspective as well. So that's great. It says, no, it's necessary. It's about asking if he's had an accident in his pants. So not wanting to acknowledge, I guess, whether or not he's had an accident, and parents trying to find out, and,
Well, a piece of that, right? So every NCOPREDIC kid that I've seen, their first coping mechanism is denial, right? Nope, I don't have it. There's no accident. Everyone, right? So when I first started seeing kids with encopresis, I was like, oh, this is this child. And then I'd seen like tons, 25 years of kids with encopresis, and they're all exactly the same. Like they all don't want to talk about it. Mm-hmm. And a piece of it is that they feel so shamed, right? Not that you're shaming them, but they feel shameful. They feel like they failed. Mm-hmm. And so then they don't want to tell you.
Right.
And so I think a piece of it is this is where rewarding the process, not the product.
Right.
So for this kid, I might say, first of all, if they have an accident and you can't smell it, I don't count it. If you don't see it and you don't smell it, who cares, right? That's a skid mark. That's a nothing. If you can smell it, if you can see it, then you need to know. You probably already know as a parent, right? You don't need to ask. So then if you sort of know, because you smell it, then you would say, I think we need to do a change.
Right.
And let's look at the little chart we have. That's worth 5, something, points. And let's go ahead and get you a little Sour Patch Kid after, because nobody likes to change. And then the kid says, oh, I don't want to. I would really like to watch the end of Bluey. You'd be like, okay, that's totally fine. Watch the end of Bluey. Let's do it at the end. But then after that, it's only worth 3, special bucks or whatever points. But I think you would recognize the kid doesn't want to do it. You want to think about approaching it in a way that is protective of their privacy with their siblings and their friends, right? So if they're coming home from school and you're like, did you have an accident? And their friend is there and they're having snack, they're going to say no. Right. They're not going to say anything, right? So you want to be like, hi, friend. Okay, you take this little snack. I just need to talk to Joshua in the room over there real quick. Did you have an accident? No, I didn't. Okay. Just because it's a friend, we're going to just say that we change clothes like Mr. Rogers, although they don't probably know him because they're too young. But anyway, when you come home from school, let's just do a quick change. That is worth this much. Actively giving prizes for things that are hard is helpful.
Yes.
Right? As parents, we do it all the time for ourselves, right? I had a hard time on going to Starbucks, right? This was a tough thing. I really think that lipstick is nice, right? So like thinking about, you need to have that embedded with kids in their day when these kids are actively having to manage something that is more difficult than usual.
Okay, excellent. Well, we've come to the end of our time. I was wondering, you had mentioned, and thank you so much. This has been incredible. I know I speak from a parent perspective, but I also, again, with the organization, there are so many things that, yes, we can go to our surgeons for, we can go to our dietitians for, but the things I think we angst a lot about as family is how are our children emotionally? How are we supposed to navigate this already complicated world and make sure that we're doing what we can for them, so they feel like proud and they have that confidence and they feel empowered, and that we can, everybody wants the best for their kids, of course. So this input has been so valuable. Honestly, thank you so much for joining us today. And I know that you had mentioned that you had some books, and if you want to recap some of that you want to refer, because I know that that's really helpful for all of us too. We go out right afterwards and start to read.
Let's see. What are the ones that I wrote down here? I definitely liked Faber Maslach. I already noted. I noted that one.
Okay.
I think the other piece, just sort of thinking about that as a parent of a kid with a medical illness, you kind of it is helpful to ramp up your parent skills, like, so that you feel really, because you're dealing with harder things. And so thinking about, so I think for adolescents, my favorite book has a terrible title called Yes, Your Teen is Crazy, which you can't read with your teen around because they will feel really offended. Although there is this alternative one, Yes, Your Parents Are Crazy, but it really talks about individuation. It talks about the 10 commandments of how to deal with the teen. I had it at my bedside when my kids were adolescents. I found it's a funny writer, he's a psychologist, a really good book. There's a podcast I have not listened to a lot of, so I hesitate in some ways to recommend it, but a patient of mine who I really, really trust, who has kids with special needs, has told me that she's really liked. It's called Good Inside by Dr. Becky.
Okay.
And there's some stuff I was listening to, one on independent play, and sort of this idea of, parenting is so tricky. And then it's like tricky squared with a kid with medical illness, right? And then it also is this moving target. So what makes a good parent of an infant, a toddler, a preschooler, a latency age kid, an adolescent, a young adult are all different.
Yeah.
And then it's this cosmic joke because we spend all this time, energy, and love for them to leave, which is what they're supposed to do and be young adults in our life, which is wonderful. But it is a real transition, and it's harder when you're worried about your child's health. And so I think the more you can learn about child development, the more it will help, because at the end of the day, your child's not going to be defined by their gas or their bag or their poops. They're going to be defined by what they love and who they love and what they're passionate about and how to bounce back when things don't go well. And that's going to be what makes or breaks their day much more than a fart.
Yes, that was great. That's awesome. Thank you so much, Dr. Bender. It has been such an honor and pleasure to have you. And I know that this will go really far with a lot of families and a lot of patients.
I'm so glad. Thank you for having me. I'm really glad it was helpful. And best of all the parents listening, you're really great parents, because being a great parent is continuing to try and continuing to learn. And you meet that definition by taking your time to listen to them.
Oh, well, people are saying thank you. Thank you for this. Thank you. Have a wonderful day. Bye-bye.